Welcome to Robert Wood Johnson University's Health Talk. I'm Dr. Douglas Ashinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Joint replacement surgery has become dramatically common among today's society. Roughly 500,000 total knee replacements and over 175,000 total hip replacements are performed annually, and these numbers are expected to increase. Joining us today to further discuss joint replacement are our two special guests, Dr. David Abrutyn, orthopedic surgeon and medical director of the Joint Surgery Center at Robert Wood Johnson University Hospital, Somerset, and Dr. Charles Gatt, orthopedic surgeon at Robert Wood Johnson University Hospital in New Brunswick. Welcome to the show, both of you.
Thank you.
Dr. Gatt, you want to tell us a little about who you are, where you practice, and what you do?
I'm Charlie Gatt. I'm the chairman of orthopedic surgery at Robert Wood Johnson University Hospital in New Brunswick. I also work, my practice is University Orthopedic Associates in Somerset, New Jersey. My practice is sports medicine and some joint replacement surgery.
And Dr. Abrutyn?
My name's David Abrutyn. I am the medical director of the Joint Surgery Center at Robert Wood Johnson University Hospital in Somerset. My private practice is with Summit Medical Group in Bridgewater, and my specialty is sports medicine with a focus on shoulder and knee surgery.
Okay, so let's talk all about what's going on now in the real world, the fact that we're now having more joint replacements than ever. Tell us a little bit about why we would do a joint replacement, who's candidates for it. Why don't we start with Dr. Gatt?
Well, the primary indication for joint replacement surgery is arthritis, but arthritis is caused by many different reasons. There could be run-of-the-mill osteoarthritis, which is wearing out of the joints. There's rheumatoid arthritis, and then there's post-traumatic arthritis, arthritis that occurs as a result of an injury maybe years ago that leads to loss of cartilage covering on the end of the bones, and that leads to a painful joint, like the hip or the knee. Patients start to note that they can't walk as long distances, they have more constant pain. Their quality of life diminishes to the point where they start to avoid doing certain things that they might enjoy. There's a lot of conservative options that are offered, and they can work through those for a while, which can provide some temporary relief. But ultimately, if the joint deteriorates to a point where quality of life has diminished significantly, then joint replacement becomes an option.
And Dr. Abrutyn, anything to add to that?
No, I think as Dr. Gatt said, that at the end of the day, when you've failed all conservative medical management, and your pain is affecting your quality of life, then you're a candidate for joint replacement surgery.
Ages of the patients who are coming to you for this? Are they the young, middle-aged, older? Are you seeing more? It used to start out as the older, now we're seeing more younger people coming in with it?
I think it's, the average age is in about 70, 72, but over the last decade or so, it's becoming younger and younger as more people are remaining more active and looking to maintain a certain lifestyle that it's not acceptable to live with pain, and they're staying more active, so they want to find a solution that will allow them to get back on their feet quickly and allow them to enjoy their life. So I think we're seeing younger and younger people requiring joint replacement surgery.
Also the fact that the two of you and all the orthopedic people, all the orthopedic physicians in this country are becoming better and better at it and doing better procedures.
Well, I think one concern has always been longevity and how long they would last, but as they last longer and the implants become better and the approaches and recovery is a little bit quicker, it's becoming more of a viable option for the younger patient.
Okay, so let's start. Someone comes to your office. They've had osteoarthritis or regular arthritis for 30 years. They've been on the anti-inflammatories orally, which haven't done very much. They come to see you. They're coming to you for the first time.
Right. So if they've worked with oral anti-inflammatories, they tend to be over-the-counter or prescription-driven. There is some options for injection therapy, either steroid injections or hyaluronic acid injections. They work on some people, but not all. But if they've pretty much run through the course of conservative measures, then we start to talk about, first discuss what the impact on their quality of life, how much activity have they lost. I will ask them specifically, do they have more bad days than good days? Do they not go out, shopping anymore? Do they not go out for walks anymore? And then if their impact on their life has been significant, I say, a joint replacement can really change your quality of life. You can go out and walk without pain again and be very happy.
And the joints that we're really discussing are?
Hips and knees, yeah.
Okay, and you had talked about implants.
Yes.
Tell me a little bit more about implants.
Well, I
Again,
think,
since we're taking basically the knee out, we're implanting something.
right. So it's not a lot of the misconception when you talk about joint replacements. People think you're actually replacing the knee. So we don't truly cut your knee out. It's more, particularly with the knee, it's like putting a cap on a tooth. So you're making some cuts on the ends of the bone of the femur, your thigh bone, and the tibia, which is your shin bone, and you're basically putting a metal cap on the end of each of those bones, and then plastic in between. As we alluded to earlier with how long implants last, one of the concerns is that where the metal connects to the bone and or with the plastic, that those can wear, and over time there's been significant improvements in terms of the strength and quality of those implants.
And again, I remember years ago we used to talk about the fact that they would last 10 years and have to consider replacing in 10 years. What is the thoughts nowadays?
So now there's been many studies, particularly out of Europe, that have shown that at 20 years, 85% are still in place. So again, when you talk about survivorship, you're talking statistics. So 85 out of 100 that last over 20 years is really good. Obviously, if you're one of the 15, that you're not happy, but 85% success at 20 years is pretty outstanding.
Which also, again, tells us why maybe we're doing it more younger also, because the thought had always been, if you do it in a 55-year-old and then it has to be replaced again at 70, is it worth it? But now you're telling us it can go 20 years, so at 55, it can go to 75 or possibly longer.
Correct.
Yeah, there's been advances in materials technology to the point where one company in particular guarantees their prosthesis, the replacement, for 30 years. So as long as it's put in technically properly, they would expect that because of the change in the way they design the plastic particularly, but also the metal covering, that they're guaranteeing the device for 30 years. So I think we can easily tell people it's more than 20 years now.
Now, is there a difference between implanting a left knee and a right knee?
The prosthesis is slightly different itself. The implant is just shaped, they're conformed to a right and a left side, so yes, but I mean, operationally, the approach is the same and everything. It's just making sure you put the right side knee in the right knee and the left side knee in the left knee.
How about male and female? Is there a difference between the two also?
There's one or two companies that have marketed some small, female designed prostheses. Again, the idea is that the prosthesis, their implant, has to fit the shape of the bones, and for them, in the most part, women have smaller bones than men. So there's been some movement towards that. However, if you look at the outcome studies, there's never been any proven difference between a gender-specific knee versus a non-gender-specific knee.
Now, again, since you run the joint center over at Robert Wood Johnson, Somerset, you want to tell us about the center, about the approach to a person who comes in, before the surgery, during the surgery, and then also afterwards. Of course, we need a lot of rehab afterwards.
Right, so with the Joint Surgery Center, we basically standardize the approach to the total joint patient. So all the surgeons in the community, all their patients are treated the same in terms of the hospital stay and post-operative course. So we don't tell the surgeons how to do the surgery, but we've really made it a patient-centric focus. Once the decision has been made for surgery, every patient gets the same information packet and brochure, which is very comprehensive. And then on the day of surgery, patients get rehab that same day. Our length of stay averages about just over 2 days for hips and knees.
Length of stay meaning the amount of time the person stays in the hospital.
Correct. Some people are candidates to go home the day after surgery, but average is about just over about 2 days. And then they get therapy twice a day in the hospital. We do it with a group. We try and treat the patients as well patients, so even though you're going to the hospital and we think of it as a place where you go when you're sick, you're actually healthy and coming for elective surgery. So we do group therapy at the hospital, and then about 80% of our patients go home, and a therapist will come to the house as well as a nurse, and then the remaining patients go to rehab.
And so, in other words, they're in the hospital probably about 2 days after surgery, and then based on how they're doing or what their home situation is, they either go home with rehabilitation starting at home, or some end up going to a rehabilitation facility to get rehab there.
Correct.
And then after that, or do they go to rehab at a facility like a physical therapy?
Yes, they'll need outpatient physical therapy either way, whether they go home directly from the hospital or to rehab. They'll eventually transition to an outpatient therapy.
And when does that patient feel as if they're back to themselves?
Usually by 6 weeks, most patients are getting around and independent. They may still be using a cane at that point, but usually the pain is different than the pain they were experiencing prior to surgery, and most people by 6 weeks are happy they did it. I would say it takes about 3 to 6 months to fully recover.
And over in New Brunswick, I assume it's very similar?
Yeah, very similar. We have the same. We could educate the patients about prior to surgery with a kind of a preoperative class, what to expect. Coming to the hospital, again, length of stays, 1 to 2 days. There's been a lot of advances in pain control after surgery that have allowed patients to go home and encourage patients to go home rather than go to rehab. The availability of home physical therapy really helps a lot, and outpatient physical therapy. As a general rule, the hips tend to recover a little faster than the knees. Hip replacement patients may feel close to normal at around 6 to 8 weeks, whereas the knee replacements, again, like Dr. Abrutyn said, is more 3 to 4 months.
Okay, now, can someone, if they've got bad arthritis, have 2 knees done at the same time, 2 hips done at the same time? Is it advised to do that, or is it better to do one at a time?
In fact, at Robert Wood Johnson, we can do 2 knee replacements at the same time frequently. Actually, sometimes we'll have 2 teams of surgeons working simultaneously and do both knees at the same time, which shortens operative time, but they don't have to be done at the same time. They can be done serially, so that's one after the other, but at the same operative setting. The patients have to be healthy enough and strong enough to undergo 2. And the same thing with hip replacements. As some of our surgeons are doing the anterior approach to the hip replacement, which is a different approach that goes in between muscles rather than cutting muscles, and the patients can get up and walk very quickly after surgery, so they tolerate both hips being done at the same time very well. So that's been a big advance in terms of the way we do hip replacements.
Okay, so before the person goes to the hospital, what should they expect? You've seen them in the office. They're going to come in to do a joint replacement at either New Brunswick or at Somerset. I assume that someone would call up, set things up. Have they what's done?
Well, I mean, primarily they go through a thorough history and physical by their orthopedic surgeon, just to make sure they're ready for surgery, discuss the surgery, educate them on what to expect. Most patients will need a medical clearance. They'll have to see their medical doctor, just have a checkup and make sure, again, they're ready to tolerate anesthesia and the operation itself. Then there's the preoperative teaching class, which I think is really the key. The patients going in to the hospital educated, and they know what the expectations are, what's going to happen when I arrive at the hospital, what will happen the following 2 days, and what will happen after discharge. That gives them a comfort level that allows them to go into the surgery with more confidence.
Now, they come into the hospital that morning, and are they brought immediately to the OR, or what happens?
Well, they go to a preoperative holding area. There they meet the nurses, kind of do the intake, so they take down their information, gather all their medications, so they know what they're going to need for after surgery. They speak with anesthesia, discuss anesthesia options, because there are different choices. And then they meet the surgeon before surgery. The surgeon always does a correct surgical site check, make sure they ask which knee or which hip are we working on today, and actually marks the hip. And even though they put a mark on the hip or the knee, they're probably asked 3 or 4 more times, which one are we going to do, so there's no wrong site surgery. So there's a lot of details that get taken care of before they enter the operating room. So most people will arrive at the hospital 2 hours before surgery.
And then the surgery happens, then, as you had said, they're in the hospital probably for about 2 days?
Yes.
And rehab starts that night or the next day?
It depends on the time the joint was done in the day, but generally we prefer to have therapy that same day, and then the following day they're on a schedule, again with all the other joint patients done by all the various surgeons in the hospital, and they get therapy twice a day. We also empower the family to become what we call coaches to help them, because we want them to also get therapy and do their exercises even without the therapist there. But they get formal therapy twice a day.
And then after that, of course, then we talked about the rehab, either going home for home physical therapy,
Right.
or going to a rehab facility.
Correct. So if they go home, they'll be arranged and set up to have a nurse come to the house to check their wound and manage any of their medications, and then they'll have a therapist come to the house for the first 1 to 2 weeks, and then at that point they'll transition to outpatient therapy.
And the two of you will see them in the office approximately how long after surgery?
Generally, if they go home, we usually see them 7 to 10 days after surgery for a wound check and to remove the sutures at that point. If they go to rehab, generally that will be done at the rehab, and generally we don't go to visit them in the rehab unless there's a problem, but usually once the patient leaves rehab, which can be anywhere from 1 to 2 weeks, then they'll follow up in their physician's office.
It sounds very nice and very easy, but I'm sure, as you both are aware, there are risks of the surgery itself. Those risks include from start to finish?
So the main risks that we worry about are blood clots and infections. They're the two major risks of joint replacement surgery. Blood clots are prevented by anticoagulation treatment. Sometimes patients are treated in something as simple as aspirin, or there's some oral medications stronger than aspirin that can thin the blood and minimize the risk of blood clots. So the risk is relatively low. If there's any clinical concern for it, we can check for it early, detect it early, so that the clot is detected in the leg before it goes to the lung.
And hopefully they've also gone through with the medical clearance, which has told you whether or not that person's at a higher risk.
Right. Mm-hmm.
So again, the smoker, you're probably going to be at a higher risk.
Mm-hmm. Right. And then the other thing is infection, which again is something we do everything possible in the operating room. I mean, our patients actually, they do a what's called a HibaCleanse scrub. There's a special soap that they wipe down the leg with the night before surgery. Obviously the operating room is sterile. Everybody practices, sterile technique, and just as much as can be done as possible to control infection. The infection rate is very low. It's in the range of 1 to 2%, which isn't very high. So.
And anything different over at Somerset?
Nope. Again, we take every prevention to avoid infection. Same thing with blood clots. It's very low, and depending on your risk factors and your prior history will determine whether you're on aspirin or something else by mouth.
Another thing that we used to worry about, which doesn't seem to be nearly the worry anymore, is blood loss.
The surgical techniques have changed to the point where blood loss is rarely a concern. We used to actually have patients donate blood prior to surgery and then transfuse them back after the operation. We no longer take a blood donation prior to surgery because the blood loss has become so minimal.
Yes, I can tell you, I remember years ago about people going in 2 or 3 weeks and giving 2 units of blood self-directed. Now I don't see them doing that at all.
They don't do that ever, and transfusions are excessively rare.
Right. The transfusion rate throughout the system is less than 3%. And that's usually higher for bilaterals because it's twice as much surgery, but it's very low.
Now, aside from the joint replacements, you are orthopedics. What else would you like the general public to know about coming to an orthopedist?
Well, I mean, orthopedics, generally is for people who are dealing with musculoskeletal pain in any part of the body. And I think, at Robert Wood Johnson, we have all the subspecialties of orthopedics covered very well with fellowship-trained orthopedic surgeons. So, we have people who are on the cutting edge of spine surgery, hand and upper extremity surgery, sports medicine. I think so. If you feel like getting around or doing the things that you enjoy, people are becoming more active as time goes on. People are staying more active and later on in life, and they worry that they're wearing their joints out or they can't do things they used to do. We can usually get people back to the activities that they enjoyed.
And you have, again, special interest in sports medicine?
Yes. So my specialty is sports medicine, and I think, like Dr. Gatt said, one of the misconceptions about orthopedists is that in many ways we're the primary care doctors for the musculoskeletal system. And even though we like to operate, and that's what we do frequently, we also primarily treat most people non-operatively. But within the hospital system, we have doctors that can treat every realm of musculoskeletal care, from sports medicine to foot and ankle to total hips and knees to shoulder, hand, and wrist problems.
And is there any back and forth between New Brunswick and Somerset? Like, is there something that's offered at New Brunswick that's not offered at Somerset that you would transfer someone over?
I think, you know, with New Brunswick, in terms of the full spectrum of orthopedics, they're a level 1 trauma center, whereas we're not at Somerset. And so I would say the most frequent thing that we would transfer is if someone ends up in the emergency room with a highly complex trauma, those are the situations that we would transfer them to New Brunswick.
But otherwise, at Somerset, we have everything that's needed.
Yeah, I think on an elective basis, we have everything that's needed from an orthopedic standpoint.
And in New Brunswick, any special parts of orthopedic at the hospital, that they do anything different?
Not that it's different. I think, like Dr. Abrutyn mentioned, it is a level 1 trauma center, and we see orthopedic fracture care as a true subspecialty of orthopedics. So,
and a level 1 trauma means
high energy accidents, motor vehicle accidents, which are in our area where there's multiple highways intersecting, is a daily occurrence here. So we do take care of complex injuries that involve both the musculoskeletal system and then also maybe some of the major organs. So the trauma team can take care of those, and we can manage patients that are much more sick because of the trauma team that's available. But as far as the fractures are concerned, we're equipped to deal with almost anything that can come in.
So it's almost as if the person, even they don't have to go to a New York hospital. You have everything possible over there.
Oh, definitely, that's the case. Yeah.
And now also with the joint replacement, you're doing things very similar to a New York hospital.
Well, we're doing them just as well. I mean, I think some of our joint replacement surgeons have moved towards, like I said, the anterior hip replacement approach, which is a way of doing the hip replacement from the front of the hip, and it's much less painful. And I can tell you, like from experiencing patients that have had it done, it can be done as an outpatient procedure. You have the hip replacement done in the morning and be home by lunchtime in your house, which is incredible. To think that, when I started training, hip replacements would stay in the hospital for 10 days
2 weeks.
to 2 weeks, and now you literally could go home the same day, for the properly selected patients. So we have our surgeons do revision surgery, so even joint replacements that were put in 10 or 15 years ago that have begun to fail, they become very complex cases. Our joint replacement surgeons are fellowship trained at
Fellowship training meaning that?
So it's an extra year of training above and beyond residency training, and it's a 1-year training where they just do joint replacements. So they learn to do the primary, in other words, the first replacement, but they also spend a lot of time learning how to redo the hip and knee replacements for the ones that do fail early.
So we're talking about people who are very, very well trained. Again, they've gone 5 years minimum to internship residency, then at least another year or so for fellowship afterwards.
Correct.
And I think, just to add to your initial comment, I think one of the things that certainly healthcare is moving towards is data. And with our hospital system, we have the data to prove that we are just as good as our surrounding hospitals across the river. And like Dr. Gatt said, we have excellent, well-trained physicians who we don't just say are excellent, we have the data to prove it from an infection point of view, patient satisfaction, functional recovery, blood transfusion, length of stay. And so really, I think within the health system, there is no reason to go anywhere else.
Well, also the fact that since it is a local hospital, the family's there. Like you had said, the rehab afterwards, it's a family rehab. And if they're going into New York to have the surgery done, the family may not be able to make it into New York, the whole family, to see what's going on and to help with the rehab.
Right, and I mean, at the end of the day, as patients, you need to do what you're comfortable with, but from a technical competence and the full spectrum of care, I think within the Robert Wood Johnson system, we have many well-qualified orthopedic surgeons, not just for joint replacement, but for all of your musculoskeletal needs.
Sounds good. Any last thoughts? Joint replacement, orthopedics over in New Brunswick?
I think the emphasis we put on patient satisfaction and quality of care is really high in the Robert Wood Johnson system, and I think patients' experience there is really very good. They go home, they're happy with their outcome, and they spread the word. And that, as you've said, the number of joint replacements is growing dramatically, and we see patients coming in with high expectations, and I do think we're meeting those expectations.
Which again, very important, and the fact that they're lasting longer also. Any last thoughts, Robert Johnson, Somerset, orthopedics in general, something you want the general public to know about?
Outside of what we've discussed, I don't think there's much else to say other than that I think from a patient satisfaction quality, the joint program is focused on the patient and not only their experience, but excellent outcomes.
Which again, important because they're not going to get better unless, one, you guys are good, the follow-up is good, the coming in beforehand, again, what you had explained beforehand, the education being so important before coming in. So it's the whole approach that is done both in New Brunswick and at Somerset Hospital.
Right.
Yes.
This concludes today's episode of Robert Wood Johnson University Hospital's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-888-MD-RWJUH. For more information about Robert Wood Johnson University Hospital's orthopedic services, please visit us at www.rwjuh.edu. Thank you for watching, and thank you for coming to visit us.
Thank you.
Thanks for having us.